that introduction. It's really a pleasure and honor to speak with you all across the ocean and across the continent. Thank you for taking your Saturday evening to spend some time learning about epilepsy and stroke. Okay, thank you very much for that introduction. It's really a pleasure and honor to speak with you all across the ocean and across the continent. Thank you for taking your Saturday evening. All right, great. So we'll get started. I think we'll have time for, we should have time for discussion, questions, and so forth. So we'll go ahead and start it. So the topic, as Dr. Saleh mentioned, is about seizures and epilepsy after stroke. Let's see if I can figure out how to do this. Oh, there we go. Okay, so start off with just a couple of points about stroke overall. Stroke is the leading cause of seizures and epilepsy in older adults. As Dr. Salim already mentioned, approximately 50% of new onset epilepsy in adults aged over 65 years. I put an asterisk about that because those numbers come out of literature about, I think, mostly Western, McDonald's eating populations, and may not apply to other countries. And I'll mention some numbers that I found regarding Ethiopia in the next slide. And just as a reminder, ischemic strokes account for about 90% of strokes, and hemorrhagic strokes account for about 10%. And that's all I'm going to really say about stroke in specific, because I'm well beyond knowing about stroke these days. I did look up some information about, what is the some epidemiology about epilepsy in your country, and I didn't find a whole lot with numbers. There are a lot of articles on PubMed. The one study from 1997 described incidence of epilepsy of 64 and 100,000 per 100,000, with leading causes being head trauma, meningitis, and I think a large proportion may be genetically related. Someone in the audience later may have some updated or new information about that. So probably not the first thing you're thinking of if you're seeing a patient there in terms of underlying cause, depending on the scenario in front of you. But certainly it is in certain countries, stroke is an important cause of epilepsy. We talk about seizures in two settings. The first setting is the seizures that occur in the acute setting. So when patients present with acute stroke, and sometimes they have seizures either on presentation or while they're still in the hospital being treated for their stroke. And we call those acute symptomatic seizures that occur within 7 days of the onset of their stroke. Whereas seizures that occur after 7 days are considered remote symptomatic seizures, considered unprovoked, and fit the ILEA diagnosis of ILAE, rather, it's diagnosis of epilepsy, that is having a greater than 6% risk of seizure recurrence. So again, there's acute symptomatic seizures within 7 days, and after stroke, seizure after 7 days is considered epilepsy. What are the numbers? If we talk about ischemic strokes, in the acute setting, not too common. Numbers show about 1 to 4%. Some studies may quote numbers as high as like 10%. Whereas in the acute setting for hemorrhagic stroke, there's a higher risk of acute symptomatic seizures in the acute phase. Talking about down the road, the incidence of seizures is about 10 to 12% of that population. And similarly for hemorrhagic stroke. And the graph below illustrates that again in the acute phase, which is blue, you see that they're more likely to see a seizure who had a hemorrhagic stroke in the acute phase compared to the ischemic strokes. So acute symptomatic seizures, you may account them clinically, often not clinically, but you may have a suspicion if you're treating a patient in the hospital with acute stroke and they might have either some focal motor symptoms or fluctuating mental status. Again, the acute stroke phase, up to 16% if it's a hemorrhagic stroke. But if you put an EEG of them, and particularly a continuous EEG in these stroke patients, in some studies they have seen about 17% of those patients had some type of epileptiform activity, that is focal periodic discharges or similar patterns, and about 10% of those patients had, in fact, had seizures, and a lot of those might have been subclinical seizures. I will mention a little bit of the pathophysiology of epileptogenesis, although I don't, reading the studies, I don't understand a lot of this. It's a little bit beyond what I do on a day-to-day basis, but I'll mention some of the hypotheses. I think this is an ongoing area of active research. But in the early phase, you can imagine there's disruption of ion channels, there's exocytotoxicity and cortisol surges, which may be involved. Later on, there's a process of developing a lesion through gliotic scarring. There's initial and later blood-brain barrier disruption and some type of maladaptive plasticity where there's increase in excitatory neurons versus inhibitory neurons. And there's some remodeling of internal networks that lead to epilepsy later on. As usual with a lot of conditions these days, inflammation likely plays a role. And there is some indications that hemosiderin deposition may contribute to epileptogenesis, particularly, for example, in patients who were found to have siderosis on their imaging. This is from a review article taken in turn from another article that illustrates some of the factors involved. So on the left side, with the early phase, they're describing the blood-brain barrier disruption, cellular toxicity, and increase in certain inflammatory markers like IL-6, TNF-alpha, interplay between the astrocytes and other cells, and there's some transition to a lesion which involves remodeling, increase in excitatory neurons, probably inhibition of inhibitory neurons, and so forth. This is again, I really can't claim any sort of knowledge about the details of this, but I do have some references that you can look at for further reading. As I mentioned, there are some risk factors that we think make seizures more likely if someone has a stroke. Not surprisingly, cortical involvement of their stroke as opposed to subcortical strokes, the severity of their stroke, interestingly, younger age of stroke onset, the large lesion volume probably goes along with stroke severity. As I mentioned, the hemorrhagic stroke subtype, particularly in acute seizures. And then also, if they had seizures in the acute setting, that is a risk factor for that we have a higher chance of developing epilepsy later on. This leads into some interesting work regarding prediction models or prognostic models for estimating in a post-stroke patient, what is their chance that they'll go on to develop epilepsy? So there's a couple of tools that have been validated in the literature. One is called the SELECT score, which is used for prognostic estimation in ischemic strokes, and the CAVE score for hemorrhagic strokes. So I'll go through this in the next slide. So in the SELECT score, again, for ischemic stroke, it is a validated tool to predict late seizures or remote seizures after ischemic stroke. So there are several components that go into this. It accounts for the severity of the stroke. Typically, you'll enter in the NIH stroke scale, whether there was large artery atherosclerosis on their vessel imaging. Did they have acute symptomatic seizures or early seizures? Did the stroke involve the cortex? And was a stroke involving the anterior circulation, particularly the territories of the middle cerebral artery? The risk scores go from 0 to 9 with a subsequent risk estimation of a pretty low risk, 0.7 risk at 1 year, all the way up to about a 63% risk if you have a score of 9 at 1 year, and an even higher risk down the road. With a pretty strong concordance statistic suggesting a decent accuracy. And so this score can be used to identify patients who might be at higher risk for post-stroke epilepsy and may guide, closer monitoring. The next slide kind of illustrates the different scores you can get with this and the graphs that show what the risk of developing epilepsy versus time is. So the cooler colors are lower scores, all the way at the bottom, which show a pretty negligible risk of seizures down at by 5 years, whereas a higher score reaching 9, there is a greater risk of greater than 60%, which would mean epilepsy. That is, they have a high risk of developing epilepsy. You'll know with these curves that most of the time the risk reaches it's an asymptotic curve, so they're reaching the risk they're going to reach by the first 2 years, which fits along with what's reported. If people are going to go on to have epilepsy, most of them will have their first remote seizure within 2 years. The CAVE score is used in a patient who's had hemorrhagic stroke. And the components involve whether or not the cortex was involved, again, younger age, the size of the hemorrhage, and again, whether they had early seizures or not. Similar score range from 0 to 4, with the higher score risk achieving about a 46% risk down the road. Again, so not quite meeting the criteria for epilepsy, and this kind of fits with what I described earlier in the slides, that down the road, it's those who had ischemic strokes that are more likely to have the remote risk of developing seizures compared to the hemorrhagic strokes. And again, this may guide your follow-up and help to counsel patients. I'll just say that there is, at this point, no proven strategies for stopping epileptogenesis. So we don't really have anything that we can give in these high-risk patients to say, okay, take this and you're reducing your risk of having seizures going forward. Oh, that's been an area of research, and we should stay tuned for that. There are also some research into other biomarkers for post-stroke epilepsy and risk stratification. As I mentioned, early EEG can be used in the select and cave scores. That is a risk factor. That certain factors on the EEG, like epileptiform findings, may indicate that they may be at risk of having epilepsy down the road. So if you have epileptiform activity on your early EEG, it's a high risk, 42% risk versus a lower risk without having those features. Regional slowing, also suspicious, a little over doubling the risk versus not having focal slowing. And I mentioned the select model. There's an updated model that includes findings on the EEG, which increases the predictive value of that score. Probably a little bit more on the research phase. I'm not sure how much this is used in clinical practice yet, but certain measures in CSF or blood for inflammatory markers, the presence of those may also indicate an increased risk. And there's a paper that describes combining the select score with this presence of an IL-1B antibody marker that can suggest an increased risk of seizures. And there are also some genetic and molecular markers that have been mentioned. Again, there are some references at the end of the slides that you can read more about. Let's get on to what we will encounter in our daily practice, which is the clinical management of these patients. So happily, I actually saw a patient yesterday in clinic, which highlights how we can think about this. So this patient was a 52-year-old man. He actually had his history of a seizure or two when he was a child, around age 7, was briefly treated with medication. His seizures resolved and he was taken off of medication. He was seizure-free until about 15 years ago when he had a seizure in the setting of withdrawal from alcohol after heavy and consistent alcohol use and abrupt disruption. At that time, he was checked out, deemed not that was a provoked seizure, and he did not have any seizures after that until he presented to the hospital in the summer, where his wife saw him fall to the ground suddenly. He was staring off. He had some stiffness of his right arm. He lasted a couple of minutes. He was in a postictal state afterwards. They took him to the hospital, and while he's waiting in the emergency room, he had another seizure over there. At that point, he was examined more urgently, and imaging revealed that he had left greater than right posterior circulation stroke, so mostly involving the left occipital and left posterior temporal regions, and a little bit in the cerebellar strokes bilaterally. He underwent a stroke workup. Mechanisms for stroke has not been found, although it's suspected to be embolic given the multifocal nature of his stroke. So they're testing him further and monitoring for atrial fibrillation. He was treated with Keppra in the hospital after he had his second seizure in the ED. And he was discharged on levetiracetam, 500 milligrams twice daily. And when I saw him in clinic about almost 3 months later now, he's been doing pretty well and has not had any seizures, recovered fairly well from his stroke, has some right homonymous hemianopsia, and has not had any further seizures, thankfully. And he remains on Keppra 500 milligrams twice daily. And he had questions about, do I need to stay on this medication? So we discussed the risk factors. So in his case, he did have acute symptomatic seizures. He had 2 seizures on day 0 of his stroke. And appropriately, I think he was treated with with levetiracetam while he was in the hospital. And that's probably reasonable. We don't want his hospital course to be complicated by further seizures, so he can, finish his workup, get out of the hospital, into rehab, do well in rehab, and get back to home. So I think, at least in my hospital, I think if they have a seizure in the hospital, they're usually going to end up on medications like levetiracetam. However, so does he have a risk of seizures going forward? So I actually used the select calculator. He did have early seizures, so that's a risk factor. He had an EEG in the hospital, which was normal, so no focal slowing, no epileptiform discharges. His NIH stroke scale was about 4. And he did have cortical involvement. There was they reported some very minor petechial hemorrhage, but I didn't really think that was a significant factor. His select score for stroke at 1 year was around 27%. His stroke at stroke risk at 5 years was around 30 to 55%. So definitely not terribly small, but not quite reaching that 60% threshold. So we talked about it. I explained these numbers. Talked about how the fact that he had these cortical lesions in the brain may put him at risk for having seizures down the road. Discussed those numbers from the calculator. And we did some shared decision making. And he was interested in coming off the medication. Not that he had a lot of terrible side effects to it, although he is feeling a little drowsy from it. But he did understand those risks and chose to try and come off. So I counseled him, it's about 3 months, let's wait another month. And if he's still doing okay, he can wean off the levetiracetam and see how he does. I counseled him and his family about what to look for if he has seizures, what type of seizures can happen, and to reach out to me if he has any of those events. I also ordered a routine EEG to be done just to see if there's any change in his patterns, if he has any epileptiform patterns which might modify our thinking about his risk down the road. And we can maybe have a discussion about that at the end, about what others may have done. So getting back to this slide, again, differentiating between acute symptomatic seizures that happen within the first 7 days of stroke, and you may or may not need to treat those patients with an anti-seizure medication. If they do have a seizure after that, then they have epilepsy by definition. The common anti-seizure medications that we're using these days tend to be the somewhat newer ones. Levetiracetam, very, very commonly used. It has a decent side effect profile. Importantly, it doesn't have much drug interactions, particularly in these patients who may be starting antiplatelet agents or maybe anticoagulation, and that's an important consideration. Similarly, lamotrigine was thought to be well tolerated. There are several studies regarding lamotrigine use in the elderly population in particular, and found to be well tolerated and continued in patients who are older, and again, fairly good interactions with other medications. There are some warnings about whether it worsens certain cardiac arrhythmias, although I've not really seen that in clinical practice. Lacosamide was a brand medication, now generic here in the United States, so it's used much more commonly. It's another advantage to be given IV, so it's sometimes started in the hospital. And so it has a lot of flexibility that way, fairly well tolerated. It also, we don't have to worry so much about some of these enzyme-inducing drug interactions. One caution is that, and most of the inpatient doctors are aware of this, is that lacosamide can sometimes lengthen the PR interval and cause bradycardia. And so that can be a limiting factor for its use in some patients. So it's important, as always, to use your clinical judgment. Every case is different, so that's practicing the art of medicine, where we consider the patient's age, what are the problems they have, what are the medications they have, what type of stroke they had, what type of seizures they have too, to decide whether, excuse me, is it appropriate to continue medication either in the acute phase or even in the long term in some patients. Even after you see them in follow-up, and they had a bunch of seizures in the hospital and they were treated with one or two medications, one might be a little bit slow or cautious about removing those medications in the long term, even if the risk factors and the numbers suggest perhaps that the risk does not reach the threshold of long-term epilepsy. Depending on the status of the patient, you may choose to keep them on a medication in the longer term. And so every case is different. Most people, in most situations, you might be looking to try to wean off medication in about 3 to 6 months, depending on the situation. And other tools like routine EEG and so forth may be helpful for you and the patient to decide how best to go forward. What happens with patients who had stroke and then epilepsy on top of that? So a recent paper that was a meta-analysis in patients post-stroke showed that there was a double the odds ratio for death in patients who had seizures after stroke. In addition, they tend to have more likely to have poor functional outcomes and increased disability, not surprisingly. Also, high risk of post-stroke dementia or cognitive issues. Again, not surprising. I mean, these issues in terms of cognitive and functional issues can arise in patients who didn't have a stroke and have seizures. So, but it's sort of a double hit if they develop epilepsy afterwards. And in the acute phase, as you can imagine, they may be associated with longer hospital stays and higher healthcare costs. And driving issues, particularly here, where there can be strict driving restrictions for patients who have seizures that can certainly affect their ability to get back to being independent, regaining employment, and that's certainly an important factor for a lot of patients, whether they've had a stroke or not. So, right, so I promise this is going to be short. In summary, as you know, stroke is a major cause of seizures and subsequent epilepsy. And in particular, hemorrhagic strokes carry a higher risk of seizures in the acute phase. The pathophysiology indicates that early seizures may be due to the factors surrounding the acute injury, whereas late seizures probably involve network and structural changes. In the clinic, after patients are out of the hospital and seeing you perhaps in a follow-up clinic, these tools like the SELECT and CAVE scores can help you counsel patients regarding anti-seizure medication management if they were on a medication by the time they see you, or for monitoring or knowing what to look for and counseling regarding the future risk of seizures in those patients afterwards. Certain tools that are available, certainly I use EEG, and these other markers may become available down the line, may help with that risk stratification. As with usual epilepsy care, management includes the appropriate anti-seizure medication selection depending on what's available to you, with regard to individualized care, that is choosing the right course depending on their comorbidities, medications, and so forth. And then counseling and monitoring regarding the impacts of epilepsy on top of stroke in terms of their mortality, cognitive issues, and quality of life. These references, just a handful, a lot of these are just review articles and you can dig down further. I just listed a few here that might be of interest to those of you who are interested. And I will stop, and thank you very much again for inviting me, and happy to take some questions or engage in discussion. So I can stop sharing if you want, and sorry about that.
Hey, thank you so much, Dr. Oommen. Can you see the questions on the chat?
Sure, yes.
So maybe you can read the questions and give us your answer. And
Sure.
if there are more questions, all the attendees, you're most welcome to just drop it in the chat box. Over to you,
Yep.
Dr. Oommen.
Okay, all right. So yes, are there particular reasons these medications are preferred? So I think these medications are preferred, like I use them, so I'll explain my experience, and then maybe some other folks can describe what they might use in your country. We tend to use newer medications, although I tend to still prefer generic medications for cost reasons, just because in general these may be better tolerated and have less interactions with medications like anticoagulation. However, I think you have to use what's available to you, whether that's medications like carbamazepine or Depakote, Dilantin, phenobarbital, just that one has to be just be more aware about what those medications might do in terms of side effects and interactions with other medications. And that will certainly factor into your decision about whether you need to treat them or not. Certainly, if they have epilepsy, they have a remote symptomatic seizure, then we have to choose something. And then I think what has to choose what's available for you. In terms of what types of seizures, I think that depends probably on the lesion. So if you have some indication for where their lesion is based on examination or MRI or CT scans, you can maybe predict what type of seizures they might have. So for my patient, he had mostly posterior temporal and occipital lesions. So you might potentially have some type of visual phenomenon, or those seizures, he might end up with temporal lobe type seizures where there might be focal impaired awareness seizures or focal to bilateral tonic-clonic seizures. Frontal lobe strokes may cause more motor seizures or frontal lobe seizure, which can sometimes be difficult to pick up, particularly seizures out of sleep. One might expect them to be more motor based if they're on if they are or they might be temporal mimics. So then again, they may start in the frontal lobe and move to the insular or temporal areas and be more temporal lobe type seizures as well. So it kind of your lesions may guide you, although as some of you may have experienced, seizures can have very strange semiologies. So it's really an educated guess. So given that, what do I counsel? How do you tell? How can you tell someone how to someone regarding how can caregivers best support someone with both stroke and epilepsy? I think hopefully they are having some type of follow-up care both for their stroke the post-hospital phase and making sure that they are minimizing their stroke risk factors. Are they on some type of antiplatelet agent, and identifying and addressing the underlying stroke risk factors, smoking, hypertension, diabetes. And I think those are the best things. And in terms of epilepsy, I think access to medication and making sure they can maintain their medication, having a good sleep schedule, and getting adequate rest. Is there a way of avoiding developing a seizure after stroke? So that's where the risk calculators, the SELECT score and the CAVE score and other prognostic tools, I think what they're going to be used more in the short term is research into preventing epilepsy. So I think prior trials in these patients, if you started giving someone and everybody who had a stroke some agent to say that, okay, let's see if we can prevent you from having strokes down the road. The epidemiology that I mentioned earlier of stroke patients, only about maybe 6% of them will go on to have epilepsy. So it's kind of hard to do a trial where the incidence of epilepsy overall in those stroke patients is fairly low. So I think the strategy is to do clinical trials of potential agents in patients who are identified as having a potential higher risk in the first place. And if you select those patients and then do some studies, maybe you'll find some agent that might work. So stay tuned. I'll just go down the list. How long should a patient with post-stroke epilepsy stay on an anti-seizure medication if they have a prolonged seizure-free period? So that's a hard question. And there are also, if you look up, there are some there are some calculators to estimate what is the risk of seizure recurrence if a patient comes off anti-seizure medication. And I think I gave a talk about this a few years ago to my practice, and asking the question in general, what's the risk of somebody having a recurrence of stroke if they came off a seizure medication, let's say they've been seizure-free for at least 2 years or more? And the answer is always is that it depends. And various studies have shown recurrence risk being as low as like 15% to as high as like 50 to 60%. So that's a pretty broad range. Probably people who have had a lesion, like stroke patients, are probably in that higher risk stage. Patients who have had maybe seizures which are more difficult to control or required more than one medication to control their seizures may have a higher risk of seizure recurrence off medication. So I think I use a shared decision-making model with my patients. I discuss that, hey, you've been seizure-free for a while now. We could discuss coming off a medication. What do you think about that? Are you having side effects to medication? And really, the choice really depends on the patient. If they're having side effects, or there's trouble, the medication is expensive, or they just don't want to be on medication, and they have some chance, they have a lower risk, they can certainly try that. Other patients will say, Doc, I don't want to have a seizure again. I'm back to work. I'm driving. I don't want to lose my license if I have a seizure. Let's not talk about this for a long time. And so both answers are correct. And is there a way of integrating stroke care? What's the best way of integrating stroke care with epilepsy? That's a good question. So not that I was thinking, that we don't have a formal way of doing this even in our practice. So in our practice, there is a stroke clinic. So patients who have stroke often do a follow-up in the stroke clinic, and they're just making sure that that the stroke workup is complete. They're on the appropriate antiplatelet or anticoagulation therapy and so forth. There isn't really much going on in terms of screening or counseling running epilepsy. If they had seizures, they end up in my clinic, or if they have a seizure, they'll end up in my clinic. So there isn't really any integration as of yet, but that is certainly something that we considered in a stroke clinic where they could incorporate some of these ideas into their counseling for the patient. Another question about how to select anti-seizure medications. So my broad recommendation is that you choose a medication that is either a broad spectrum, or if you can use a narrow spectrum agent that is going to be tolerated, that's what I would choose. So there isn't any, and really most important in terms of selecting the seizure medication is number one, what's available. Number two, what will match the patient? There are not a lot of studies that show that, oh, one specific medication is the best. So I'm really trying to match the medication to the patient's profile. Their age, are they going to tolerate this medication? What are their other medications? I want to avoid medications that might interact with their anticoagulation, like their warfarin. And do they have mental health problems? Do they have, and what medications might be suitable in that setting as well? So you have a lot of tools, of course, depending on different settings, that may be more or less restricted, and you have to choose what's available for you. But my counseling would be choose a medication that will best fit the patient. Keep on going. Great questions. How can we support the mental health of stroke survivors coping with disability and epilepsy? I think that is an ongoing issue. And certainly, I think, some of us epileptologists tend to say, focus purely on just, hey, are you having seizures, or yes or no? And if you are, how often are you happening? And we're focused really on the management of that. But as we all know, epilepsy is not just seizures. It's really all these other issues regarding their social disability and their cognitive disability. I think that as much as possible, we use a team approach, depending on the resources available to you. I, in particular, am not hesitant about using medications to target people's depression or anxiety if they need to. Even for where I practice, getting access to mental health care is available, and but there's still a shortage of that. There's long wait times. Primary care is involved in treating those kinds of issues as well. But for example, in terms of mental health, I screen or ask about that at every visit with patients. Hey, how are you feeling? How is your mood like? Ask the family. We often do screening tests for depression and anxiety and get a sense of that. Try to address it as possible because it's a very common comorbidity, and then engage either community resources, psychiatric help, therapists, as well as is available to you. How long does a seizure-free patient regarded that is epilepsy-free? So I think this goes back, if I recall the top of my head, I think the ILAE has some definition of this. I think it's seizure-free for 10 years and seizure-free off medication for 5 years can be called a resolved epilepsy. So that's a pretty long time window. But there's some idea, perhaps, there's a concept that, somebody has frequent seizures to begin with. They're having a seizure every 3 months, and then they go 9, 12 months or more, or 2 years without a seizure. That's a pretty good indication that you've gotten good control. They have good control of their epilepsy. Whereas somebody who has seizures perhaps once every couple of years, that inter-seizure interval is longer. So I think you would have to wait longer, at least 3 times that inter-seizure interval. So let's say somebody has a seizure every 2 years, I would probably be hesitant to say, hey, you're seizure free, until they've been seizure free for, let's say, 6 or 8 years.